Good afternoon. This is Harvey Rosenthal from NYAPRS, the New York Association of Psychiatric Rehabilitation Services, and Tanya and I, our Deputy Director, Tanya Stevens, we're both very sorry we couldn't be with you today. We did our best to work with the airline to try to get there, but we would have missed our connection, and so we're doing this presentation because we really wanted to respect the time you're spending today and to say hi, and I'm hoping we'll see a few of you over the course of the next year. So the presentation we're going to give now is about the Peer Bridger program that we're going to be coming out over the next few months to support you in, and I think we'll be on the phone as well on a regular basis. So we're very committed to helping and supporting you and to being available for any questions or concerns. Next slide, please. So I really wanted to start with this slide because at the end of the day, it's really about the relationship and the work we do in human services. And even more so in peer support, the key to peer support, the critical distinction and the reason it works is because of the relationship that we establish with our peers. I'm a person in recovery, so this is very, very personal to me. So when I say our peers, I mean that I'm a peer as well. And so, you know, I was in college many years ago, and I did a paper on theories of counseling. And what I concluded as I looked at it and what the research said was, in the end of the day, it's not so much about the theory of counseling, it's about the relationship. And so that's really the key to what we're going to talk about today. We can have all, you know, a really great model, well thought out, well proven, but it's relationship by relationship that really makes this work. So we'll talk about that over the course of the presentation and over the course of the year. Next slide, please. So I want to tell you a bit about my own story, because here at NYAPRS, almost all of us are peers, and again, the work is very personal to us. I had my first major episode of severe depression way back in 1971, and I wound up in a hospital on Long Island in New York, and was there for 6 weeks. And I can tell you that in the midst of that experience, I didn't expect that it would happen, and I didn't know what had happened, and I didn't know what would happen in my life. Was it over? How was I going to fare? What had happened to me? What's possible for me? And I can tell you what was critical at that moment, because I didn't know inside what was going on, what was being reflected back to me by other people on the outside. And so the relationship that's offered to you when you're in this state is so critical, and the cues that you pick up from people. So if the cues you're picking up is something awful has happened to you, and your life will never be the same in the worst way, and people are expressing some distance and are acting like you're very different than they are, and the boundaries are far, that really communicates in the worst way at the worst time. So really, I think a lot of them, again, the magic of peer support is the relationship and the ability to get with what's going on with the other person and to validate it and support it rather than to take distance and to pull away and to act in a way like your life will never be the same, but in the worst way. One of the important things about peer support is being able to be a peer supporter gives meaning to what happened. On a spiritual level, it's in a sense that you experience this struggle, and I believe, and partly to pass it on and to be able to share the hard lessons with other people. And again, if you're a peer and you're in the system, very often you've been, at least in the past, really encouraged to be a recipient, a receiver, but not a giver. And there's dignity in giving and in sharing and purpose. And again, that's the added value of peer support. Next slide, please. So I eventually crawled up to Albany, New York, the state capital, from Long Island after I got discharged. And I wound up working in the psych center because, again, I wanted to really share. I cared about what had happened to me and others, and it looked very clearly, I expected, and I was right, unfortunately, that the treatment that people getting, the cues that they were getting, the forecast that they were getting was very negative. And what I saw was just that. I worked on the inpatient unit, and I'd sit in the treatment review meetings, and I'd see how the staff would operate. And the messaging that came to people was, this is a life sentence. You're going to be permanently disabled. You're going to have relapses is part of the equation. It's not even something that can be avoided. Readmissions are inevitable. And that you'll never have relationships and you'll never marry, which means you'll be isolated and on the fringe and on the margins. And in many instances, folks have socialization, particularly in the hospital, only with each other in a segregated way where staff are involved. And that's not, as you know, it's not normalizing for people. You're told you'll never work. I heard that again and again. And that people, I don't think, realize when they say that to people, that's a life of poverty and all that that means. And the loss of meaning and identity. When you meet people, they say, how you doing? What do you do? And we don't have an answer if we're unemployed and on benefits, and we're just going to programs. And again, folks were encouraged, I don't think on purpose, it fostered a dependency. And people were led to believe their judgment was poor and they couldn't make good choices, and that staff would be required. And that's very disabling as well. Sometimes it's not the symptoms that are as bad as the way one is treated and the results of that. And again, I mentioned earlier the boundaries. If they were severely sort of distant, we were all of a sudden talking about people like they were them. And that's extremely depersonalizing and damaging. Next slide, please. So here am I working in the state hospital, and I'm working with young people, and particularly young men, because I understood that experience. And it broke my heart to see people that were coming in the system and to see the messaging that they were going to get and the life that they were going to expect. And when I would work really hard, and every time somebody had a relapse and a readmission, I would really struggle with that. It was an important event. And I was just told, and certainly in those days, it's just the illness. There's nothing we can do. There's nothing they can do, and there's nothing we can do. Such a low bar, and it was expected. I watched this, a psychiatrist pointed to the rehab unit and said, voc rehab's not an option for people with schizophrenia. How awful. I was once told by a psychologist, don't use the term recovery. It gives people a sense of false hope. And even if people don't say that, if that's in the air, that's so damaging. And I was written up once because I was spending time with people in the community. That's when I worked in a clinic. We were sort of led to believe you stay in your office, and if people don't show up, it's because of their being non-compliant, and review in 3 months. Hopefully that's not happening at this point. It's our job to go and be where people are and to start where they are. And Tanya will talk more about that. Next slide, please. So what came in the 70s certainly began to be very powerful is the transformational sort of movement of recovery. And we took that, the despair, and turned it to hope for people and encouraged people to move past the shame and the silence and the secrets and to establish dignity in their lives and to see beyond being a patient in the mental health system. It's not like people had fallen off the planet. They were going to be in a segregated world of being a mental patient, but that they could retain or achieve their personhood. And that things were personal. There was a personal value and meaning. We want to support people to do that and to help them move past idleness, where people are sort of, because they're poor, they're eating poorly, they're idle, they gain weight, they contract diabetes, and all the issues with that. And a big part of the movement, too, is offering people faith and encouraging a spirituality, a personal spirituality. Next slide, please. The rehab movement is so critical because at the time it really reinforces that people are encouraged to have goals, and the goals that they want. You can reality test the goals, but you got to start with the goals that people have and not try to talk them out of them. And put in play the rehab sort of process, establish goals, so, you know, identify the skills that are required and put in place the supports. Choice is critical. You know, we take that away from people with a diagnosis. So really important to focus on people's choice and self-determination, even if it means within a certain realm of safety that people will fail. That's how we grow and that's how we learn. The focus from illness to wellness, and a focus from deficits to strengths. These are critical, and we need to bring that every day to our work and in our peer support to each other. Next slide. So a few years ago, SAMHSA began saying now recovery is not only possible, which we were saying in the 80s and 90s and 2000s, it can be expected. Everyone can recover. The most disabled person, there's research to show people on the back wards of state hospitals back in Vermont, I'd say 30, 40 years ago, were able to recover in a substantial way because of the supports that they were given, both in the hospital and in the community. So it's about raising the bar and expecting higher outcomes and changing those roles and giving people space to have a meaningful role and a meaningful sort of relationship and breaking down some of the boundaries and helping people to move from idleness and poverty to education, employment, economic self-sufficiency. And there is an element that is unsettling to people, sometimes to the people in recovery, their families, or the staff. There is a sense of responsibility and risk in learning, and there's a reasonable amount of risk that's really required. Next slide, please. So these are two of my favorite quotes, and we very often would tell people, don't work, it'll be very stressful for you. And Joe Maroney, who is known to Melody out there, and some of the folks out there, I believe, he would say, if you think work is stressful, try poverty, unemployment, and social isolation. And Pat Deegan really was a hero, has been a hero in our movement, and she's the one that really applied the term dignity of risk and the right to failure, and that was really so important for folks to have the dignity of risk. Otherwise, we would take that away. Don't get too stressed, don't work, don't try too much, you may fail, and then we encourage people to be in the system for their lives. Next slide, please. Whoop. There we go. So on public policy, the transformation really, as you know, is about deinstitutionalization. That's what you're focused on in Washington, again, why we want to support you. And not only is it the right thing, but it's the law. We have to serve people in the most graded setting according to the Americans with Disabilities Act and the Olmstead decision. And we have to move not only from custodial care to the community, but there's a lot of custodial care in the community still. And we really want to support people, and we do in peer bridging, to have, to integrate in the community and be independent. And one of the other advantages for the state when you have a recovery sort of formulation is you make savings, and if the savings are reinvested, you grow the system. Next slide. NYAPRS is very proud to be a part of that movement for the last, I'd say, 30 years. And we are at this point a 36-year-old peer-led statewide coalition that has a national profile. We bring together New Yorkers and other folks around the country in a unique sort of partnership, peers and providers, and peers who are providers. And our mission is to advance policies and programs and social conditions that advance recovery, rehabilitation rights, and community inclusion, and for all, regardless of gender, race, what have you. Our three legs of the stool for NYAPRS has been we do a lot in the way of advocacy, we do a lot in the way of training and TA, especially for providers. And we've created, and we'll talk about that today, we've created innovative models of peer support going back to 1994. Next slide. This, by the way, is our contact information. There's our website. There's our email addresses. And if you want to get some daily emails from me about what's happening in New York and in the country and in terms of trends or studies or grants, you can join on that line there, that link to be a member of the NYAPRS e-news. Sorry about that. Next slide. So when NYAPRS began, it really started out as an advocacy group, and the peers in our community came to Albany for the first time and were the voice of themselves, the voice of the people in the peer community. And we joined other advocates in working successfully to pass a law that closed 5 state hospitals over the 90s and reinvested what came to be $200 million into the community. It helped sort of create the peer support and rehabilitation movement. In the first year, when the funding became available, the priorities of the state were to help folks leave the hospital and promote recovery, community integration, and to expand the use of peer support. And so we combined the two and wrote a grant to create a model that would ease the transition of the community for folks being discharged from New York State psych centers, and to reduce the likelihood of readmission. And I'll tell you, we're very proud. We've had our project since 1995, and we've probably helped thousands of New Yorkers to leave and stay out of our state hospitals. And I know we've gone from 6,000 to 8,000 that we had back then to 2,000 and less that we have now. So we're very proud of our part in that. Next slide. So the model, I'll end with this part. The model that we proposed and somewhat modified is these steps, that the model would begin in the hospital with people that had been there for years or people who were coming back again and again. In many instances, those folks were very apprehensive about leaving, weren't sure they could manage a relapse, were being told by folks they couldn't, and we're frightened, and the staff were frightened about having them go. We're very protective of people, as I said. So the important thing is to start with people where they are, which in this case was in the state hospital, and our model began with peer support meetings that in those days didn't exist in many parts of the hospital. And these were run by our peers, trained peers that Tanya will tell you about, who created these peer support meetings. And folks would come to the meetings, and whether it was a referral or a self-referral, they would get involved in a mutually responsible relationship with a peer, a NYAPRS peer bridger. And over time, they would develop the personal goals and strategies together. It's important for me to tell you that the goals need to come from the person, and that the peer, and Tanya will talk about this, whereas we can be asked to be part of the treatment team meetings, we represent the person in order to have the credibility and the impact. So we're of the person, we're the major ally of the person being served. And so it's important to start with their goals, not necessarily our goals. Tanya and her bridgers in our other projects do a lot of work engaging people in the community, and I can tell you the engagement does not start with, so you have a mental illness and you need to take medication. And she'll tell you where it does start, but it starts with the putting out the fire of what's led people to come into contact with our system. So there is the engagement in the relationship, the development of the personal goals. I think we used to do a skills and support inventory that helps folks really assess in their own words, in their own view, what their strengths are, what their needs are. And out of that, we'll develop an individualized wellness self-management plan, plan to grow community skills, relapse prevention, and crisis management. We really want to help folks figure out in advance, why didn't it work? Why doesn't it work? What could we do to help? Next slide, please. The fifth step is as we get folks ready for discharge. Now in New York, in many instances, people get passes from the hospital. And unlike what you have in Washington, our bridgers live in the communities where the state hospitals that we're working in. We have 5 state hospitals we've been working within the surrounding communities. So we're able to work with people in the hospital. They go to a peer support meeting. They spend more time with our bridgers, and they start exploring the goals related to transition to the community. Very often we're able to go into the community and takes people out on passes and start to look around at what the next life is going to be like for folks, and where they're going to live and how they're going to eat and how they're going to manage. and it really helps, as you can imagine, to know where you're going and that you're not going to fall off a cliff from getting this wonderful support, and then it will be withdrawn, and you're not supported in that transition. We want to have the continuity of the relationship. We don't really want to be a model where we get people ready for discharge and then they disappear. We turn them over to somebody, and at a critical moment they have to start all over again. So the continuity is really important, and I hope your model can support that. Along the way, we're connecting folks with natural and service-based supports. I think you want to go back a slide, please. Okay. And again, their peer support meetings, I'm not sure I said that, their peer support meetings not only in the hospital, but in the community. So even after discharge, the folks are able to maybe see their bridger, even if they're less intensively involved with them. The bridgers are around in the community doing the meetings as well. Next slide. So as I said earlier, our project began working out of 5 state hospitals, one on Long Island, one in New York City, one in the southern tier, the Mid-Hudson region of New York State, and one here in the Capital District where we are. And originally the teams had 3 bridgers, and these were part-time jobs. And frankly, people considered this back in the day to be an entry-level job and for people who really didn't want to get off their disability benefits. Tanya will tell you in a bit, these have become very sophisticated roles and jobs and well-compensated and full-time jobs with full benefits. Because people are using their hard-won experience, taking that into some meaningful sort of career. And you see it all the time. It's a great gift to see. And again, we established the peer support meetings I mentioned, but what we observed after we got the project up was the supervision, and Tanya will talk about that, is critical, and critical that it comes from somebody who knows how to support peers, and in this case is a peer. So we hired we went to the state, got another round of money to hire peers who could supervise their own peers, which is in sync with what we want to do. And supervision is very important because if people are supervised different ways, sometimes the system will see our peers as, I used to hear this, cheap staff who will get people to go to their appointments and take medicine. And that's not at all where we start and what we are. I will say if people want us to do that, and that's part of what they want, we will do that, but that's not where we start. It's important. And we're not cheap anymore. This is a real job and well paid. And the other thing we needed was to get another round of money to hire trainers, because the staff, honestly, in the hospitals and the staff in the communities were not set up for that. The staff in the hospitals had seen people be very symptomatic for a very long time. So it was hard for them to imagine that folks would be ready to leave. And excuse me, it wasn't until some of the bridgers came to the hospital to work, the staff had not seen them in years, and were just amazed at how well they were doing. And that in itself was an education. But we did a lot of education, and we do with staff, that recovery can be expected, and here's how to support people in a person-centered way and things like that, and both in the hospital and in the community. We want to raise understanding. We want to get support from people for this person-centered, recovery-centered way, and we want to have the kind of collaboration with the surrounding staff. I will say, too, that there was an issue in the state hospital where the staff were very standoffish with our bridgers and saw them as a threat to their jobs. That didn't happen in some instances. In other instances, probably even if we hadn't been there, the hospitals are retooling. But that was really not something that we wanted to see happen, was the bridgers were going to be sort of foiled or limited because the staff were afraid of them and what that would mean for them. Next slide. So this is our mission in a graphic. We support each other to get out of the hospital, to stay out of the hospital, and to get the hospital, the institutionalization and the despair and the fear, to help get that out of people. So I've really enjoyed speaking with you. I wish I could be there. We will meet at some point, and it's my pleasure to turn you over to one of the best leaders and managers in the country, and certainly the the best operationalizer of peer support I've ever seen, and that's Tanya Stevens, our Deputy Director.
Thanks, Harvey. Good afternoon. Again, to echo what Harvey said, I'm sorry that we can't be there today, but I'm just going to sort of go through the model itself so that you all have a better understanding about what the bridgers will be trained on and what the expectation for the program is. Okay. So, the real basis, Harvey sort of touched on what peer support was, and that the relationship was sort of the central vehicle of which we see, the program being designed around. And a lot of our program is designed on Sharing Mead's model of intentional peer support. And these are just a couple of quotes around, what does peer support do for people? It's an intentional relationship that we form to help us get unstuck out of places that have not worked for us in the past. So we build relationships that are respectful, that are mutually responsible, and potentially often mutually transforming. We really sort of sit together in a supportive way, a very intentional way of relating to move us towards what we want and visions we want to develop for ourselves. It's a way of thinking about power and really questioning power, and not just how power has been asserted over us, but how we give power or expect people to take power over us. We say in our relationships that we should get as much as we give in the relationships. We're not there to fix or help anyone. It's really about being in relationship with the person and being responsible to the relationship. It's also about challenging our status quo and being able to look at where we are, what we ourselves have done to sort of get us stuck in the place that we are, what our own responsibility is and our own actions are, and whether or not we're really happy with where we are. Helping people sort of move towards what they want. Oftentimes we think about things as moving away from what hasn't worked from us, as opposed to what do we really want. And then building mutuality and rethinking what help means. Oftentimes with people who are deeply institutionalized, we wait for somebody to come and do for us. That's been the expectation, and that's been the message, that we're incapable of doing for ourselves, and that what we need is for something to be done for us. And these relationships really help challenge that and then support us moving towards things. It's also about a full respect for the individual process of change. Just because, I'm also a peer, Harvey talks a little bit about his own story. That doesn't necessarily mean that we have the same story and that we have the same process of recovery or what recovery means to us. And so in these relationships, we fully respect that individuals are going to get on their own recovery pathway and make choices that are going to be theirs. And that's why, as Harvey said, the choices really need to be self-driven. They need to come from the peer themselves. Peer support is also social action or social change. It's not just program or treatment or services. It's really a fundamentally different way of approaching the work that we do. Important to distinguish what peer support is not, and it's not about just being friends. I mean, we are always going to be part of somebody's community, whether we're their peer bridger or not, but it's not just a friendship. That doesn't mean that we won't be friends at some point with people we work with, but again, it's an intentional, purposeful relationship that we're developing that goes beyond just friendship. It's not traditional or clinical treatment, but it's also not adversarial to traditional or clinical treatment. We see ourselves as adjunct to the services that are in play. And a lot of times we'll get questions around if somebody has an AOT, if somebody has intensive case management, if somebody has a whole number of services, can they still have a bridger? We feel like, the more services a person may have, the better for that person, the more opportunity for that person. We're just an additional part of that person's overall support and treatment, and we can work in conjunction together. It's also not about assessing, prescribing, predicting, or controlling. And what that means is even if, an individual has displayed the same behavior or made the same choices or had the same pattern in the past, we're not going to automatically assume that that's going to happen again. We're coming from a place of not knowing with that person and not automatically just telling people what they need to do or what may be wrong with them. We're going to listen differently and approach them as though this is, a new story to us that we really want to hear about. It's not about fixing or helping, as I said before. The individual's overall recovery and success in that recovery is not ours to own. We are there to support them on their own pathway. We're going to allow people to be able to make mistakes or make decisions on themselves and support them in that effort. And we're not going to fix or take away from people in having to make those decisions. And it's also not about taking responsibility for each other. We're responsible to the relationship and only to the relationship. So we commit to showing up 100% of the time for that relationship with the person. But that doesn't mean that we're taking responsibility for the individual. And we're not asking the individual to take responsibility for us. The basis of our relationship is really hope, empathy. We build a trusting relationship. There's a lot of time talking with people prior to, Harvey mentioned we go on off-grounds passes with people, but there should be a lot of conversation that happens before we're just going on off-grounds passes. What do we need to feel safe? What is going to make us feel trusted? What do we both need to feel safe in that situation? And we're both going to be held, mutually accountable to that. We're going to have respect and reliability, and by that, my time and that individual's time are both important. So if we make a commitment to meet each other at a certain time, we expect that we're going to be there. Not just that we expect that the peer is going to be there, we expect that ourselves are going to be there, that we are going to show up, and that we're going to be reliable. We're going to be something that people can count on. It's also about fostering personal empowerment and personal responsibility. So again, what have we done to participate in our own pathway at this point? Although we often give our power up and let other people do for us, there are certain things that we need to sort of be held accountable for, and we need to be able to view those and say, how do I take responsibility around either some of my behaviors or some of my choices? Not in a way where it becomes self-blame, but just that it can be the impetus for change in that. And we also approach all of these relationships from a place of, trauma-informed services. We don't provide direct sort of service and healing around trauma, but we do come from a place of sort of honoring that people come with a story, and that we're not going to over-analyze around how people are doing certain things, because there's probably more of a backstory that we need to know about. Start where the person is, both in their life and in the community. We do engage people in the state hospitals. I'll talk a little bit at the end about a couple of other programs that we have where we engage people in the community. But again, the idea is about supporting people in the pathway of recovery. We can be an ally and a supporter. We can share our experiences, but only in a way that helps sort of foster the trust, foster the self-accountability. It's not about us oversharing, because that's a concern that we get sometimes. Is there oversharing? How do you know when you crossed a boundary around that? And it's about sharing your experience, in a purposeful way that makes a person feel supported, that allows a person to feel heard in some way, and that we can be an ally. And we can also be an advocate for the person. Now, when we say we're an advocate, we really foster more self-advocacy than we do direct advocacy for people. So if an individual is having some struggles at the hospital or having some struggles with their treatment team, we're going to really work with them to be able to advocate for themselves. We might role play a situation. We might work with them to change the conversation or the patterns that have been happening. And again, we can go to treatment team meetings, but only in support of the person. So we're really there as that person's support, as that person's backup, as that person's rock, if they ask us to be there.
Tanya, I just want to say a word or two about that, because I know it's going to be an issue. Is again, our peers are certainly happy to be in the treatment team meeting, but as an ally of the person, in support of the goals that have been identified. And we would probably ask, the first question is, can the person be in the meeting? We would not want to be behind closed doors talking about the person for whom we've engaged in some trust. Just while I have the floor, a couple of things. That we're not overly influenced by the chart. We don't want to read the chart in the way that we're buying into an illness or patient view. So it's important for us to really moderate that. And the other thing Tanya said, and we are reliable, but we are relentless. I want to really say that. Peer support, peer supporters, NYAPRS style, and most other, we are relentless. We don't give up on people. We keep sort of coming back, and that's very critical. Thanks. No, you're not back?
I am.
You are.
Having to moving this.
Sorry about that.
Okay.
I'm very chatty.
So as a distinction, the peer bridger is not a case manager. Ideally, we could work in conjunction with case managers to make sure that all of the supports an individual is going to need out in the community are in place. But it's not the job of the bridger to actually put those supports in place. And it's an important distinction because oftentimes people will be seen as sort of assistant case managers. The peers will be seen as people who can go, help get somebody to an appointment, help get somebody's paperwork filled out for Social Security. And those are things that a bridger can do if the individual asks for that level of support from us, not as a need that is decided as part of somebody's treatment plan. We're also not, as we just discussed, a member of the treatment team without the permission of the person served. We're not a substitute for formal crisis services. So we do a lot of work around crisis. We are often called at somebody's point of crisis. But for actual crisis services, we're not supposed to be seen as a substitute for what the person may need in that moment. And we already discussed about assessing and prescribing. So here are some of the project services that we can do with people. We can do skill teaching, again, at the request of the individual. We provide emotional and social support and also recreation and companionship. We think that recreation is an important part of what the relationship is that we do, that it needs to come at a balance for other service areas, but that sometimes just getting out and being able to function in the community and do something fun is a big step for people. We work on developing the self-advocacy and the mutual peer support, and then we also discover community with people. We see ourselves as community guides in both defining what community means for the person and what aspects of community people want to be involved in. Again, some key practices. We start where the people are. If we really meet people at whatever place that they are and let them sort of define and move towards the goals that they seek. We try to see things through their eyes as opposed to ours. So no matter what the diagnosis or the chart or the past experiences have said, we really want to hear what have your experiences been? What's happened as opposed to what's wrong? And then we support and connect people to multiple pathways to recovery. What I always say to the bridgers is that it's not that the hospital is not an option for people. Let's let it not be the only option for people. So oftentimes it is the only choice that people have when they're struggling. Sometimes when they need a medication refill, it's the only way that people know how to take care of themselves. So what if we increase those options by tenfold, so that it becomes one of 11 choices that a person has on a continuum of multiple pathways of recovery. We also honor multiple worldviews with people. Our way is not the only way. My pathway to recovery is not the same as Harvey's, and it shouldn't be the same as anyone else's that we work with, and we really respect that. We also respect that there are many ways of seeing the same thing, and although we have shared mental health experiences, our experiences have made us sort of unique, and that they're unique to us, and just because something works for me doesn't mean it's going to work for somebody else. So we can share what has worked without prescribing or insisting that other people choose the same pathway. I talked a little before about, we really appreciate the impact of trauma and abuse on people's stories. We approach every person as though they have a story to tell, that every person has things that have fundamentally changed them as an individual. And that is, their sort of trauma or story, and that we don't necessarily have to hear that story to be able to appreciate that coping is often mistaken for symptoms, and that pain can manifest itself into strange, actions or perceptions or even relationships, and being able to appreciate that in our approach to people and talk about experiences instead of illness with people. What happened as opposed to how are you dealing with that, or how has that been diagnosed in some ways. So our project really starts, we're going to go through the sort of different aspects of what we do, and our project starts at the point of outreach. How do we, and we distinguish between what outreach is and engagement. We see those as two separate services, and they're often used as interchangeable words, and for our purposes, we really, it's important to be able to distinguish between the two. Outreach for us is physically looking for the person. So at our state hospital program, we get referrals from the hospitals themselves. Sometimes people are self-referred. We don't do as much direct outreach because we know where people are. We can find people. That's really just our definition of time spent looking for a person. Engagement is the time spent actually talking with somebody, getting them engaged in the idea of recovery, getting them engaged in the idea of the relationship that you're offering, You know, it takes patience with that process. You may have to go back multiple times. We found that even just because a person says, yeah, I'm interested in that, doesn't mean that they fully understand what they just sort of committed to, what they're going to be responsible for, and what we're really sort of seeking in that relationship. And part of engagement is really describing what is it that we're offering. We had to be very clear around, you know, we are here to offer sort of a very purposeful relationship that's going to support you in your recovery. And that engagement can take time. It's not sort of a 5-second, are you interested, okay, great. It's really going back and building that relationship from the onset with people. You know, we change how we do first contact with people. You know, we want to present what we want mirrored back from us. Oftentimes, you know, our bridgers, many of them have been with us for a decade, and so they're well known in the hospital. And what I say is your first contact is not the first time that you actually meet someone, because people are going to know you before they are even interested in the project. So we need to make sure that, you know, we're using language that we want mirrored back, and we're using language that's respectful to people and allows people to choose for themselves how they want to describe their experiences. You know, and we do a lot of, we're going to talk a lot with the bridgers about the idea of language, and the language that's sort of been given to us and the language that's been used to describe our experiences versus the language that we would choose. And really, what's the difference between uncomfortable feeling and a symptom? And do we want to describe everything that's happened to us in a clinical way, or is there other language that we would choose to use? And so we really ask the bridgers to be able to think about what is their narrative, what do they want to say about what their experiences have been, and how do they want to approach people in a way that's going to allow people to sort of choose their own language around that. You know, and then we work with people. So we ourselves, all of the things that we work with people on, the bridgers themselves have sort of been asked to do as part of their training. And we do an exercise called restoring our lives. And then the idea is that we would be able to sit with people and do this once we're engaged in a relationship. And it's about, again, restoring what has been our story. So the story of, you know, maybe how you got to the hospital, or what's been said about your experiences, versus how do you want to say that? What are your words about that? What are your experiences about that? You know, I'm an individual that was hospitalized as an adolescent, and so I didn't have a voice often in what was happening to me because it wasn't about my treatment. It was about my family engaging. And I didn't feel like people were listening to my experiences. So I was being talked at or about often. And how do you restore that sort of experience as an adult? I think that's a common experience, even for people who are hospitalized as adults. That decisions are made, or things are said, or, you know, diagnoses are given to people that may not fully express what the experience has been. And how do we support people to kind of reclaim that and be able to articulate their experiences in their own words? You know, we do a lot of our work from listening differently. We own what our personal biases are. And we even try to build relationships around, you know, if our personal biases for some reason are going to get in the way of building that mutual relationship, then we should pick a different bridger. We should be able to own those and either be able to move beyond them, or, you know, be able to say that this is not in the best interest of the individual. We listen from a position of not knowing. And I think that's important because we find often that the same person might be telling the same story for the 125th time. And it can be tiring, but our place is that clearly somewhere in that 125 times there's still something the individual feels has not been said or not been heard in some way. So how can we approach every time as a new time? Providing validations. I mean, a lot of this comes from motivational interviewing techniques, and we do go through a lot of that with the bridgers in their training, and just really being able to listen differently for people and ask questions that are going to really, you know, be able to find kind of a spirit or a vision within people, even when they say they might not have one at the beginning. As part of our relationship, we also learn to sit with discomfort. You know, as humans, what we often do is either ignore or walk away from discomfort as opposed to addressing it. And we ask in our relationships to be able to stay in the relationship and negotiate safety and need around that. You know, talk about how you're feeling about it as opposed to jumping to what the individual should do about it, and really just have a conversation about when something feels uncomfortable, and just being able to say, I feel uncomfortable with that as the start of the conversation without blaming the other person for making you feel uncomfortable. Often the conversation will go more like, well, you shouldn't have done that, or you know, you did this, and so, but really sitting with the feeling and saying, I feel uncomfortable and here's why, and being able to negotiate that in the relationship. So the sort of final aspect and the ultimate goal is to bridge people to the community. And a lot of that comes from defining what community is. Because community isn't just where you live. I mean, it can be, your community can be your neighborhood, but it's also, it's also the associations that you belong to, or the identities that you have, or the different places that you find yourself. And it's not just necessarily about friendships. I have a son in elementary school, so there are a couple of different communities that I find myself a member of as a result of that. And all people, I mean, there's often intense dog walking communities that people have within where they live, depending on the time that they might go to the dog park. So those are all communities, and how do we participate in them? Communities can be formal or informal. It can be an actual organized event, or like I said, it could just be at the dog park. And the expectation is that the bridgers are really community guides. Upon hiring, we ask the bridgers, what do they do and how do they participate in the community? It's not our expectation that the bridgers are, deeply entrenched in their communities, but that they have some idea and engage in some form of sort of community that they're able to articulate. And so the bridgers can sort of support and guide people around that. And that they can introduce people to powerful networks. We don't expect the bridgers to know everything that might be of interest to people, but we expect that the bridgers are able, when a person says, I'd like to find a faith-based community somewhere, I'd like to find a poetry community somewhere, that the bridgers are able to really seek out and help people develop those communities and engage in those communities. And that part of our listening differently helps to really engage with people around who might say, well, I don't know if I have any interests or know what community means. Where are some of the strengths and capacities that people express that might lead to a community of interest to them? And I sort of went through this with, again, we expect that the bridgers are well connected and that they're trusted by the connections that they have, and that they're able to sort of hear for other people's talents and interests for them. One more thing I would just say about community is community is not just something that you get from, it's something that you give to as well. And its purest definition, we get and give. So communities can also be, do you volunteer somewhere, or are you interested in volunteering somewhere? And reframing the idea of us getting from community and also seeing it as a get back, like a PTA might be a perfect example of this. So there might be things that you get from a PTA, but you also are expected to volunteer or serve or do some things within that community. And that's really, working with people to see that it's not just sort of us showing up and participating. Fully participating means that we're giving back as much as we're getting. So here's some frequently asked questions about peer support. How do you advocate in peer support? Again, nothing about us without us. So we don't advocate on behalf of people. We really empower people to be able to advocate for themselves. This is just a quote from a person who was involved in our Peer Bridger program around how peer support challenges people to grow. And it's just mostly that, the bridgers talk to us. They talk really with us. And really help us unpack some of the things that might be standing in our own way. How do you supervise peer support? We have a particular model of mutually responsible supervision that we will be going through with the training at the end of the week. And we should be building the same sort of mutual relationship between supervisors and the staff that we're building with the peers that we're working with. And what I mean by that is, being able to have direct conversations, being able to talk about what the needs are between the supervisor and the individual. Each relationship, every person isn't supervised exactly the same. So each supervisor and supervisee need to build their own relationships around that and ask questions and negotiate for needs. And the supervisor's job is as much around career development and personal development as it is around making sure that the job gets done. That's not to underplay the need to make sure that the job gets done, to have clear policies and procedures, to make sure that people are clear around what the expectations are and what their role is and what the organization's sort of mission behind that is. Here's just some data from 2 different studies that we had in 1998. There was a study that was done, and 19% of the individuals who enrolled in the program were rehospitalized at that time. And then again, 2012, we did our own evaluation in which we found that 72% of the individuals were not rehospitalized in the state psychiatric centers after engaging with the peer bridger. Here's some data from 2013 about the number of people engaged. We do have some more updated information, so we can send that over if need be. But just numbers of matches, number of people we work with and referred from the hospital. Again, the number of people who were able to transition from the hospital, or who were released, and then who have not returned within 3 months. And then just some statistics on who transitioned from inpatient to on-grounds or off-grounds residences, and the total number of people discharged. I think the most stagnant statistic here, though, is the number of people who are assessed to be discharge ready and who are still waiting for community housing of some kind. We also do peer support meetings and staff trainings. So the number of peer support meetings held at the state psychiatric centers, and then the number held at the community, and then the number of people that we determine, because we do collect information on unduplicated individuals, so the number of people that we serve in the peer support meetings as well throughout the year. Did you want to go through this story, Harvey, or did you want me to do it?
Well, you might get it more accurately than I do, but I can give it a shot. This is something we're very proud of, and we eventually, the next project we took on after the state hospital, we were approached by Optum Health, who was doing a precursor of the health home model in New York, and we worked with them in the borough of Queens, and we had a wonderful bridger in the borough, a strong recovery and very engaged in 12-step. And we were referred to a fellow who had been admitted to detoxes 7 times, 4 different facilities, 2009, and the Medicaid spend was very high, $52,000. And so she got involved with him. She kept going to the mother's house. He was never there. Hard to engage, hard to find sometimes. Why wasn't he there? He was out using. The mother eventually got to him the message that this bridger was very sincere. She was coming on a regular basis. She cared. I think he got admitted to a detox in Far Rockaway, Queens. And rather than go to the same kind of rehab that hadn't worked, she took him to a rehab out on Long Island. She drove him there. And she picked him up when he was ready to get out. She took him to her 12-step meeting that night. And she continued to engage with him, would visit or call him on a regular basis. And a year later, he only had 1 detox and 1 rehab, and the Medicaid spend went heavily down. So, I mean, that's an example of how we were able to work with people in a personal way. And this fellow had both issues with mood, he had kidney problems that were secondary to his drug addiction and his alcohol use. So he had major issues across the spectrum, and yet he was very successful. And for us, it was an example of what we can do. I just want to say while I have the floor, I know I'm yawning a lot. It's not because Tanya is not of interest to me. We were up late trying to figure out how to hoping to come to visit, to fly in last night. So I apologize for all the yawning. Oh, am I doing this?
No, I muted myself, sorry. This is just some data that we have. We have a project with a behavioral health organization and also a managed care organization in which we do peer bridging for individuals who have sort of who receive their Medicaid through these companies, but are largely community-based. So they're going in and out of the hospital for short periods of time, and we're engaging them in the community. And here's some outcome information that we got from our project with Optum, where we were able to show almost a 50% decrease in the percentage of people who use inpatient services, and a significant decrease in the number of inpatient days, and increases in outpatient visits for people. We're also able to show a decrease in the total behavioral health costs. As I said, we also contract with Health First, which is a large managed care organization here in New York, the state of New York. We were able to enroll. We don't have outcome information from that, but in our first couple of years, we're showing about a 69% enrollment rate. So we are able to outreach and engage, close to 70% of the people that are referred to us. And the number of contacts between the bridger and the individual can range anywhere from 1 to 78. And the amount of time, or the average number of contacts is about 18, and about 15 hours that we would spend with people.
So when you see 1 to 78, the key word there is relentless.
Mm. Okay. Did you want to talk about this, Harvey?
I can. We just want you to appreciate that peer support is really a sophisticated intervention now, and peers around the state here in New York and around the country are getting really good outcomes. And so we really want to, helping people get to work, you see in the bottom, helping people in the middle to achieve housing. We have, a world, a internationally sort of recognized crisis respite program. It's a house-based program that's an alternative to being in the hospitals, has high outcomes as well. So we just, we want to acknowledge that Peer Bridger is just one of a number of peer models that have high outcomes and are very effective.
So this is the sort of training that all of our Bridgers get to be able to be qualified to work for us. So we have our own training, and that's what we're going to go through this week. Again, the end of this week with the Bridgers there in Washington. It's largely based on intentional peer support, and many of our Bridgers have been to the 5-day IPS training offered by Sherry and her staff. They're also trained facilitators in Wellness Recovery Action Planning, or WRAP planning. They've also been trained as whole health activation in the whole health activation management sort of group design. They're trained wellness coaches. There's a program that's sort of a whole health peer wellness coaching program that started here at a university in New Jersey and has sort of spread around, at least in this area a little bit, on really working with people on both physical and behavioral health at the same time. They are OASIS certified, so that's the Office of Alcohol and Substance Abuse, in addiction as addiction recovery coaches, and they're also certified by the state of New York as peer specialists. So they've received their certification and gone through that process as well. Talk a little bit about the compensation. There was a national study done on the compensation of peer specialists, and I think the importance here is just to demonstrate that, again, as Harvey said, even when our project started, it was seen as a way to subsidize the benefits that a person might be getting, and that's really moved from what many states, more than half the states, have certification and have Medicaid billing for peer specialists at this point, and this sort of shows what the average pay would be at various different organizations, including our own. So it ranges from community and peer-run organizations to about $15 an hour to inpatient facilities at about $25 an hour. And our Bridgers, we've worked very hard to move them all to full-time positions with benefits, and the average pay is about $19 an hour for people. In 2005, our Peer Bridger program was actually recognized by the Health and Human Services Association as one of 4 programs that really were doing great work in this idea of moving people from hospital to community. And there's a paper that was sort of written as a result of that we can send over and have made accessible to you. The other programs that were spotlighted were the Georgia Consumer Mental Health Network, Recovery Innovations, and the Opt-in Peer Link program in Pierce County, Washington. So I think, the most important kind of takeaway for us today is just to really make sure that the real integrity of peer support is protected in the work that we do, and how do we continue to support models of doing peer support that keep to the integrity, that really put integrity as sort of a focal point in what we're doing, and prevent against the cooptation of the peers themselves in sort of non-traditional environments. So how do we fully both appreciate the role, support the role, and make sure that the role is seen for what it is and sort of protected? Do you want to say anything about that, Harvey?
Well, I just think it's very critical. I mean, peers, I imagine in Washington, but certainly around the country, are being, it's now very desirable or fashionable or expected to hire peers, but all too often the peers are supervised to be more medical, more like care managers, more like compliance experts, or in the part of a treatment team, security, they have the keys. That's for us not really true peer support, and I think we've explained how important the relationship is. And so, if you have peer-run agencies out in Washington, and we'll find that out because we'll be there a bit later tonight, I would say. We want to encourage and endorse the special sort of relationship that we want the system to have with peer-run agencies. We think they're very unique, and the kind of supervision that folks are going to get and the kind of deployment will be a win-win for everybody. I will say, while I have the floor, there is the diversity of what our model can do. In the state hospitals, we say we start where people are. Well, it wasn't hard to find where people are. They're in the state hospitals. And in many instances, we're kind of motivating people and energizing them. They're sort of stuck in an institutional sort of life. But in the community, with the kind of folks that Tanya was talking about, where our outcomes are so high as well, we have to look again and again and again for people. And very often it's about trying to help folks have some grounding. So it's a very different approach. One of them is more energizing, and the other one is more of a grounding and focusing. And in peer support, is able to do that. Our peer support can do that.
So these are just some resources from here in New York State. All of the certified peer specialists in New York State go through a set of online trainings in the New York Academy of Peer Services, and there's a link for being able to check that out. There's also a link for the Peer Specialist Board itself that includes, our code of ethics and grievance procedure and that sort of thing. And then there's, again, our contact information for training, technical assistance, or if there's just additional questions about peer bridger services here at NYAPRS. So again, I echo Harvey, and I apologize for us not being there. It is unfortunate after all this planning that, but I hope that this presentation was helpful. I'm sure that we'll have plenty of opportunity to be able to exchange ideas and see each other again in the future. And I think that's it.
Yeah, we're really looking forward to coming out. We'll end where we started. Peer support and recovery values are part of the transformation, and not only helps people transform their own lives, but it transforms the service settings and the system itself. And so we appreciate that Washington is committing itself to this kind of transformation, and we're delighted to be able to come out and support you in that. We'll see you this evening, those of you, or tomorrow in Seattle, those of you who are going to join us there.
Thank you.
Thanks a lot. I'm going to get some sleep now.